All right, what I want to talk to you about is CLL, which is chronic, and it's lymphocytic and leukemia. And so it's in your blood, emia, leuco, which is the white cell, it's the lymphocyte, and it's chronic as opposed to the acute leukemias. So the chronic lymphocytic leukemias, CLL, are chronic, which means a lot of the people have no symptom, they're asymptomatic, or the symptoms they do have are B symptoms, which are constitutional symptoms, fever, malaise, easy bruising, fatigue, this kind of thing. And they might have lymphadenopathy because CLL is also a small lymphocytic lymphoma if it goes into the tissue. And you're going to do a bone marrow to confirm it, and the CLL and the peripheral smear. This is all hematology. So the way it comes to me is infiltration or the side effect of the disease, the anemia, or abnormal white cells, or decreased platelet count. So the way it comes to neuro-ophthalmology is anemic retinopathy, which is going to be multifocal bilateral hemorrhages, can produce the Roth spot, or you get an infection because you're immunosuppressed, or it could be from the treatment of the disease, not the disease itself, immunosuppression. And so if you have pancytopenia, we're worried about infection. The other strange thing about it is when you have white count that's very, very elevated, you might get hyperviscosity. And so that is going to produce a side effect of the disease, but not from the cancer, just from the hyperviscosity. And that means we might get central retinal vein occlusion or bilateral retinal vein occlusion or cortical venous sinus thrombosis that might come to us as papilledema. It's rare for CLL to directly infiltrate into the orbit or into the brain. So those would be rare manifestations of CLL. The way it can come to me though as a mass or in the orbit, an orbital lesion, is if this thing transforms into diffuse large B-cell lymphoma. And that transformation of one of these clones into a different, more malignant variety is called the Richter transformation. So the Richter transformation means that one of the CLL clones got a second hit, a genetic lesion, a genetic mutation that leads it to become more malignant. There are a number of these different genetic mutations, and they're quite heterogeneous. Those aren't that important for an ophthalmologist, but you need to know that if you have CLL, you might have a presentation that looks like lymphoma. And that presentation is the Richter transformation, because normally the things we see with CLL are the chronic manifestations, anemic retinopathy, vein occlusions, hyperviscosity states, and secondary infections. So if someone presents acutely with a thing that looks like lymphoma, even though they have the liquid form CLL, you got to worry about the Richter transformation.